Thanks everybody for having me. I grew up in upstate New York, and it's good to have a little bit of I've gotten soft since I moved to Texas, and it's good to have a reminder of what everybody puts up with and how exciting it is when it does get warm. A little bit of background on sort of, I guess, me, myself, and then a little bit about this crazy name Aunt Bertha, where it comes from. It's probably the first question we get in almost every one of our meetings, so I figured I would share it. So I came to this problem not as a healthcare expert, and still don't consider ourselves healthcare experts at all, but came as somebody who was very interested in the problems of how do people get enrolled in public services. And so I decided after graduate school that I wanted to leave technology and somehow weaved my way back, and spent 4 years with the Texas Health and Human Services Commission working on a really interesting project. And a lot of people don't know this, but the state of Texas grows about 20% in population every 10 years. And the way the original sort of, what you would call it, welfare system from before welfare reform evolved was that the state would actually open up offices in which people would need to come in if they actually applied for, Medicaid, the TANF program, SNAP program, children's health insurance, to a local office. And so it sort of just evolved from that. And it got to the point where there were discrepancies or disparities, if you will, because of population growth. So what happened is the infrastructure didn't keep up with the population growth. So as people were moving in from rural communities into the bigger cities, they were experiencing long lines. So if you had to renew your benefits in Houston, for example, you might spend all day waiting at your local eligibility office, but you might be in West Texas somewhere, and there would be no line whatsoever. And so the state, under Commissioner Albert Hawkins, took on a very aggressive project, and it was, at its root, designed to store dignity into the process of applying and receiving social service programs that are funded by the state. And so the idea being, there's 143 different either flavors of Medicaid that you can get or state programs. Somebody should be able to call a number, fill out an application, and then get enrolled. That was the thinking. He also wanted to use technology by opening up self-service, either through a website or even accepting faxes. I had a chance to work on that project for 4 years, and it was a fascinating project. Specifically, I had a chance to work on it during a period of time when the economy tanked in 2008 and 2009. And my team at the time, I was the director of reporting and analysis, was responsible for things like forecasting the amount of calls that the call center would get so that we can actually staff it appropriately, which was quite the amount of precision if you think about it. When you look at 500 agents and then you look at things that are happening economically, but also things that are happening in the policy of it. So for example, if the state sent out a confusing letter, typically you could see 3 days later the volume of calls would spike. And so Stu Scruggs, our CIO, was responsible for that forecast. And what's interesting about it is he got really good at forecasting the breakdown of calls per hour of the day, because people would call on their lunch breaks and after work and in the mornings and things like that. But it was really difficult to account for external factors. Well, we really screwed up underestimating the demand for the enrollment in food stamps. It went up fourfold. And so there were long wait times, and that was a valuable learning experience for me, as during that period, I actually had a chance to fly up to Midland where the call center was and actually put on a headset and listen to people's calling in all day that were having trouble either enrolling or getting renewed in food stamps. A lot of people were newly unemployed, some for the first time. And one woman that was calling in particular that I remember is she was renewing her food stamp benefits. And in Texas at the time, in order to renew your food stamp benefits, you had to have an interview with a state employee. And so she received her renewal package, got it all filled out, sent it back to the state a day after she received it, and then received a letter in the mail from the state that said her appointment with the state employee to go over the details in the interview was going to be 6 weeks after her food stamps were going to expire. And so she asked a very simple question: what am I supposed to do in the interim? And that question is something that I've been working on ever since. And the agent, who was very caring and compassionate, probably had taken several calls that day of the same manner, basically said, maybe find the nearest food pantry. So I then started off on this journey, and here we are 7 years later. So I left and started Aunt Bertha. Some are wondering about the name. What we're really trying to accomplish is to have, when people are facing difficult circumstances, and it could be anything from you find out you have a disease, you lose your job, or you're trying to enroll in a government program, it can be incredibly intimidated. We're not trained for this. We don't practice this in schools. Nobody wants to be dependent on these programs. And I find that it's been incredibly confusing. And when you look at nonprofits' website, usually they're designed for people who are raising money. And so you can't help but feel poor when you're navigating these social services. So the idea was that sort of an eccentric family member that we all kind of knew had growing up, the one that would basically never forget a birthday, but just sort of chew us out, if we ever kind of messed up. That was the play, but it was so Aunt Bertha picks up where Uncle Sam leaves off, because I'd worked for the state. However, it was originally supposed to be Aunt Sue, but I was starting a company, and the domain name cost $3,000, which I didn't want to spend at the time, bootstrapping a company. So I did a straw poll after researching baby names from the 20s and 30s, and landed on Bertha and then also Martha. And the straw poll was between my sister and my girlfriend, now wife, and we landed on Bertha. The good news is the domain name was $13.95, which was perfect for my budget at the time. So I think we've taken a different approach. Oops. And we use the term seeker. And again, we definitely are not coming from a clinical setting. We've sort of landed there with some of the organizations that we work with, but the concept of starting with the seeker is where we really try to focus. And a seeker is anybody in need. It could be any number of situations. And I think the sort of the beauty of it all is that we're all seekers at some point in our lives, whether it's something that we've experienced as a child, or something that we've experienced as an adult, whether we have a sick kid or aging parents. We're all going to be there. My story, and we all have a story, is I got married April 1st last year, and this is my mom, and we had a chance to do the mother-son dance at the wedding, and it was a very happy moment. But we've been through a lot together. In 1992, she caught a rare brain disease called encephalitis, which caused permanent brain damage, particularly memory loss, and also she was subject to seizures, which meant she couldn't work anymore. She was a very smart, strong-headed person. Physically, she was fine, other than the seizures. You wouldn't know it by talking to her that something happened. But the way it was almost like somebody erased those parts of her brain, like you would on a hard drive, to where she didn't remember the previous 20 years of her life, which included my birth. I was 17 at the time. My younger sister, she didn't know who we were. And so growing up in a small town in Western New York, we very much saw the disconnect between finding help, certainly if you couldn't afford it, and getting enrolled in programs. And I didn't set out to do this stuff, but those memories of navigation on her behalf, originally my father, and then I became her legal guardian since 2002, so still am. She's actually in skilled nursing. She requires 24-hour care. And the neat thing is about the wedding is she did her physical therapy, and they used it as motivation, so she was able to get out of her wheelchair and do the dance. The vision, and again, coming from sort of an outsider's perspective, is take healthcare out of it. People ought to be able to find the services that they're looking for and then apply for them. If you think about it, it's been done in a lot of other industries. So, for example, if anybody has heard of Indeed.com, the job search engine, it's pretty interesting in that you could find almost any job in the world if you use the right terms, and it's indexed, it's there. And then in many cases, the agency that's hiring or the company that's hiring, you will accept an application through that manner. And that's kind of what we're attempting to do and the way we're sort of going about it. We took a few different approaches. This is, at its root, is we decided not to go through an interview or go through an assessment. And that's what's been really interesting about sort of healthcare's approach to addressing social determinants of health. The very first version of it actually asked a series of interview questions. Since I came from a large state eligibility system, I thought, well, if I just knew a bunch of stuff about the user, then I could do a better job of recommending services, because it turns out there's a lot of services. But the idea being is we would just put a search out there. It was me just entering programs into Excel, indexing food pantries and things like that in the state of Texas, and it would return a list of programs. And I'll do a demo in a bit. But then what happened after that is we started expanding, and this is something that we're launching soon. It's called Search Trends, just past 1 million users. You can see New Jersey's pretty dark up here on the map. We see a ton of what people are searching for, all the way down to the grain of the zip code. So from folks that are looking from healthcare as from sort of the population health angle, it's showing some pretty valuable data. So for example, the third most searched term in the state of Texas is actually dental care, which I find really interesting. But we don't see that in other states like Florida and others. And part of the reason is that based on the Medicaid rules on a state-by-state basis, some will cover that and some will not, depending on what you're enrolled in. And it's interesting to see these policy things showing up in the demand of what people are looking for. We see opioid usage a little bit more prominent in states like Ohio, a little bit of Pennsylvania, all the way to very private searches on things you would not, you'd be surprised by. Very intimate things that they may not want to share with their social worker. From a public policy perspective and from a population health perspective, we're hoping to work with some researchers at some point. To basically say, hey, what are the things that we're funding in our communities, et cetera, and are we funding the same things in which people are searching for? We may not be. One of the examples that I've seen is in Houston, there were 220 food pantries when we did this analysis. But when you looked at the reports, only 3 of those food pantries were open on Sundays. It turns out most of the food pantries are staffed by faith-based organizations, which a popular day for that when there isn't church on Sundays or other services, they happen to be on Tuesdays and Thursdays. So if I'm a funder in those areas, I might be interested in funding a nonprofit organization that is willing to be open on Sundays. One of the other things that we've seen is how do you get close to where people are? There's certainly a little bit of a digital divide still. And an interesting project that New York City did was replace all of the phone booths with these. I don't know if you guys may have seen these kiosks. They're all over the city. And they're high-tech kiosks where you can go charge your phone, get on Wi-Fi. Aunt Bertha was put on the kiosks in April of last year, so it's been almost a year. And we see probably about 10 to 15,000 users every month. And this is where they all are around the city. And when we look at the logs, we're seeing things like people looking for a temporary shelter at 12:45 in the morning. I've seen searches for drug addiction, and then 5 minutes later, the same user searching for spiritual counseling. And I'll allude to this later, but what we're seeing is a finer granularity of information that we may be able to act on, hopefully, potentially someday in real time, where good social service providers that are there could intervene in those moments. So that's just a little bit of backstory. And this next, what we started to notice is some of the people that were doing searches on Aunt Bertha worked for healthcare. And so that's how we sort of understood what social determinants of health actually means. So we saw users coming from health plans by the hundreds, hospital systems, and it's free to use, and Bertha.com, anybody can use it. And we started to think, what's going on? And so we ended up having a breakfast at Magnolia Cafe in Austin with an innovation medical doctor that was in charge of innovation for his health plan, and he basically just explained it to us. So we did a little bit of more work, and we just surveyed what's going on in hospitals, how are they addressing these issues. And so we surveyed in partnership with GLG, Social Impact. GLG is based in New York, C-level staff, medical directors, and a little over half were in larger facilities, 250 plus bed facilities. The rest were in smaller facilities. And what we noticed is that, looks like something that happened in the translation, but a large percentage of the challenges, people decided that, agreed that they weren't spending enough time with patients to navigate on behalf of the social needs that were happening. And 83% stated that this will become more important or critical to longer-term success as they're starting to enter into more risk-sharing agreements with health plans. They're starting to see the wave coming. There it is. So 5% reported no problems with tracking and measuring social service program referrals. And there are some great organizations out there that have been doing this all along. Some different quotes from care teams. A lot of it's dependent on who knows what. People update their own resources. There's a lot of turnover amongst the care coordinators in these organizations. Different departments don't really work together. And really the thinking is how do we operationalize this work in a healthcare setting? And so we used this slide just to sort of talk about how do we get to the population of the patients we serve or even the communities we serve. There's the reach of the care team, which is usually depending on how much the organization has invested in it. Some ACOs are investing more in building a team of care coordinators. Some health plans are hiring care coordinators by the hundreds, but they can only make so many phone calls. They can only spend so much time with patients, and certainly doctors are incredibly busy, and maybe there isn't enough nurses. But then if you expand it a little bit further, there's the reach of staff beyond the care team. So in a hospital setting, if somebody is on the phone with a patient, maybe they're talking about their bill and maybe helping them sort of figure out how to pay for it. Or there's also the reach of community organizations. Are we partnering with schools to get at some of these social problems that are happening before it becomes a bigger thing? Then, of course, is the reach of the family members. And then lastly, it's the membership themselves. Could be patients, it could be those ex-offenders, it could be students. So this is sort of the context. And what I think might be happening is I was reading a really interesting book, and I just wanted to share it. It was called The Social Transformation of American Medicine. Has anybody read that book before? It's by a guy named Paul Starr. It was written in 1982, and basically what he did is he looked at American medicine over the years, and I'm only a little bit into it, but I found some really interesting debates that were happening around late 1700s, early 1800s about how do you sort of democratize information so that people could essentially help themselves. Now, the example that he uses in here actually applies to medicine, but I think some things are happening on the subject of social work. Or even counseling to some extent. There was an author named William Buchan, and he wrote a book called Domestic Medicine. And this is what's quoted by Starr. The best known of these works was William Buchan's Domestic Medicine, described in its subtitle as an attempt to render the medical art more generally useful by showing people what is in their own power, both with respect to the prevention and cure of diseases. Published originally in 769 in Edinburgh, and 2 years later in Philadelphia, Buchan's Domestic Medicine remained popular throughout the mid-1800s, going through at least 30 editions in America. And it was probably the most influential book of its kind. If you think about it, we were much more rural of a society back then, and so there just wasn't enough doctors around. So folks were, in many ways, for simple things, actually treating themselves and learning, and in many situations, maybe the matriarch of the house was actually quite astute in handling a lot of these things. What's really interesting is there's another quote from that book, which I think you guys may find interesting, is one autobiography of one lay doctor suggests how easily medical practice might be entered. In 1844, James Still, a freed slave in New Jersey, bought a book of medical botany and began preparing remedies for his family. One day, in return for some sassafras roots, he agreed to cure a neighbor of the piles, hemorrhoids, and borrowed a little wooden mortar and a long stone to pound the herbs. Having prepared the remedy, I took it to him, and it had the desired effect. In a few days he was well. I was pleased, and so was he. It did not occur to me at this time, however, that I was practicing medicine. I thought I was but doing a friendly service to a fellow being. I just wonder, could we do more, not necessarily on the subject of medicine or sort of the medical side, but how do we democratize the way people find and deal with social problems? Is that something that a care team has to do? Having a chance to work with all different types of organizations, we're seeing some really interesting pilots across the country. So we work with a team of parole officers in San Antonio that are very focused on reducing recidivism in the prison system. And for ex-offenders that are leaving the prison system, it's increasingly difficult to find employment, to even be enrolled in social services based on the type of, if you committed a felony, it's very difficult. And so people are starting to change the role of parole officers. It used to be that maybe the job was to find them doing something wrong, but they're changing that, which I think is really interesting. We're also seeing, you guys know about the efforts being addressed by health plans and hospitals, but we're also seeing community colleges think about the role of academic advisors, in which one community college that we work with in Dallas actually is encouraging academic advisors to get more involved. They actually did a study for 9 months, and in this study, they shadowed students and tried to figure out why are they dropping out of community college. And it turns out they're dropping out of community college because maybe the grandmother dies and that was their only childcare situation. And so there they are without childcare and they can't go to school and get their classes. Or another common scenario was somebody's car broke down and it cost $450 to fix that car. And that's another reason to drop out. And the structural way that community colleges are evaluated is based on the dropout rate. And so what Dr. Jomei is doing there is really bringing training and resources to every academic counselor is meeting with students every so often, but just to check in with them a little bit more. You don't have to be a licensed social worker to do that. And maybe if you find out, for example, that they're struggling with transportation, you can structure some programs. And one program that they structured in Dallas was the ability to very quickly, and they did this by talking to the local Dallas Metro, is to give them free bus passes and train passes if you're a student and you're automatically enrolled. And some of the other things that we've heard out that other folks are doing is looking if people's utility bills are actually being shut off. The community college has very powerful relationships in many of our big cities. Why not just pay the electric bill if it means keeping them in school? Because maybe you get that $400 or $500 back when their student loan check comes in, which they process anyway. So these are just good examples that we've seen of how people are democratizing the practice of social work. I'm going to skip a few of these. One of the other things that people ask about is, if I'm a health system and I decide to hire more and more social workers, is that going to make a difference? Is that going to make a difference to the entire cost of treating these patients and the things that I'm measured against? And a really important way of finding out whether or not you're able to make that difference is, one, is to track where you sent your patients to, but then to also track whether or not that patient showed up, got the services, which is an important point of measuring that. And we call it closing the loop. And then once you know that, let's say, for example, you follow a cohort, let's say you have 100 patients, and you know that maybe 50 of those patients actually got services, maybe 50 did not, you can then take that data and compare it to your claims data and other things to be able to see, is the hiring of these social workers actually working? And I want to share with you a quick project that we worked on in the state of Colorado, in which 53 nonprofit organizations assisted the state of Colorado in enrolling people in the ACA. They're called the Sisters. What they did actually is they used software to actually allow for the self-scheduling of those appointments. And why that was important is that, one, they actually were able to know what time the appointments were. Here's some of the results. This is a heat map of the search activity that was happening in the entire state of Colorado. You see most of it is centered in the bigger cities. But of the 53 participating agencies that made 18,332 appointment referrals, 14,117 people showed up to their appointments. And then 7,420 were enrolled in a plan. This is really interesting in that there are fragmented organizations that are beginning to work together. We are only really at the beginning of this, but just imagine if we can work on standards. So it doesn't have to be one software company, it could be 50, in that health systems are able to see whether or not the people they referred out actually got the services. It might show that hiring 100 social workers may make it worthwhile and spending that time in that moment. It may not, but what the hope is over the next 3 to 5 years is that there's enough data to give decision makers and CEOs and health plans the evidence that they need to invest in these types of programs. And with movements towards value-based care and cost-sharing agreements, who knows, that might even be possible. I know there's some pretty interesting programs coming out with Center for Medicaid and Medicare Innovation. One that we're associated with the Camden Coalition in Camden, is a way of actually sort of allowing the gist of the grant was that if somebody has been in the emergency room twice over the last, I think, 6 months or something along those lines, then they qualify for navigation services in which they meet with a social worker and they can actually help them find social service programs. And then they're going to study that and actually help to see that. And it might affect the way things are reimbursed in the future. So this is something to keep an eye on. So structurally, there are organizations that are incentivized to help people navigate non-medical needs. I think we've established that. There are cost-sharing agreements that allow experimentation. I think we've established that. I want to share a couple of radical ideas, I guess you would say. This is based on some search logs that we were able to see. In Round Rock, Texas, which is a suburb of Austin, we know that they were doing searches from 1:45 a.m. to 5:45 a.m. And based on the logs, and we don't know who this person is, I still don't, it's completely anonymous. We know that they were looking for cash assistance. They were also looking for shelters. With every web search, you actually have something called an IP address, and there are third-party services that allow you to figure out, if it was from a business. It's not, you can't tell down to the person, but you can tell, the organization, the network that they're on. This user was on the network of a Motel 6. And so, obviously, in this particular moment, on this date, from 1:45 a.m. to 5:45 a.m., probably not chronically homeless, I would just guess, probably in one of the most precarious situations that they've ever been in. And what's really interesting is that there are people who have interest in making this person into, helping this person into a more stable environment. Likely, they've exhausted their family options if they're in this situation. But if they're enrolled in Medicaid, there may be a chance that they are, or even in a commercial plan. They might have insurance, who knows? Every one of these plans have a call center somewhere of people that take in calls. Could we, if we find out if they're a United Health plan member or one of the MCO plan members, could you ask them and could you say, would you like to speak to somebody someday? I don't know. Something to think of in the long run, in that with the availability of data, you can imagine being able to look and say, would you like to speak to a counselor if they're searching for things like that? You still don't need to know who they are. You still allow people to navigate for themselves anonymously. Many of us work in behavioral health, and I think the incentives are aligned policy-wise, but these ideas aren't getting out there as often because it's seen as impossible, and I don't think it is. I think the data is starting to show what is possible. And lastly, if I'm, let's say, a plan or a social worker or a coach who sits and navigates with people, I can try and find a social service program, and I can give a quick demo of the way we approach it, which is just one of many approaches. But sometimes the need is actually just pretty simple and straightforward, where if they could fulfill that need, maybe it would solve some pretty interesting problems. What if alignments and sort of the finances are structured around the whole person and not necessarily the service that they're receiving entirely in some respect? Could a social worker at a hospital just be empowered to just buy what they need, in that particular moment, versus going through the hassle? I mean, we've seen situations where a health plan is insuring pregnant women, and in some situations they find out that they don't have enough food, and they've actually empowered their care coordinators to go to the local grocery store, buy groceries, and drop it off at their house, because the probability of that baby being healthier, which they're on the hook for insuring after that, is higher if the mother is actually eating. But I was also just ordered a book and watched a C-SPAN video. It's called The American Healthcare Paradox. Have anybody heard of the book? It's pretty interesting, and they're talking about basically the social determinants of health, and she uses a pretty powerful example in the book about somebody who is diabetic and who is living in an abandoned home and had a couple of toes amputated, and turns out he just had some pretty ratty old shoes. And sort of the question at the end of that section was, a good pair of shoes costs $50. Something to think about in terms of sort of radical ideas there. Again, the reimbursement alignments need to be in place, but I definitely believe it's a solvable problem. So working with about 90-some organizations as organizations that we work with, as well as 1 million users and thousands of social workers, if we're going to fix the problems in terms of what we can control, what we're seeing is that empowering a few folks to navigate on behalf of the most expensive patients or members, the reach is so small. And you may say, well, if they cost so much per year in the utilization of services, maybe it's doing something. But what are we doing program-wise to touch those that might either be falling into extreme situations? How do we sort of catch them before they fall into very chronic and difficult situations? Based on our experience doing this, as certainly an advocate on behalf of somebody, but also somebody who works in this space every day now, it's far bigger than the reach of your care team. So what are the partnerships? I think movement towards accountable care organizations is absolutely helping. We were just part in Massachusetts, I think just launched an ACO statewide, which was really interesting on how they brought the community together. Whole person care initiatives out in California are starting to show some promise. There's going to be some more examples, but just educating the entire staff, whether it's somebody at the front desk that guides people, visitors to rooms, all the way to clinical teams, to know that there are ways of self-navigating. if you choose to. We're seeing a lot of that. Some people are putting the URLs of helpful things in their discharge paperwork and handing it out with them as well. Just a little bit of a summary. I do believe the problem will get fixed, but part of it is to look at it a little bit more from the outside and sort of put ourselves in the minds of the seeker. And I think it will stem some creativity. If we get bogged down to workflows and things like that, I think it prevents progress. I had a good discussion with an organization that was really interested in how do we get sort of the ultimate workflow into their EMR system. And EMR systems are complicated and expensive, and I guess you could do that, and certainly we integrate with EMRs, but the broader problem is the solution doesn't have to be perfect on day one. Just allowing self-navigation is a really important aspect of it. So I will close with that. I want to thank you, but I'm also happy to sort of dive in, give you a little bit of an overview on what we're seeing, or we can open up for questions. Okay.
Anybody? Not all at once? Yep. I'll come right back.
Sure. Hi, Shahid Shah, Zydus Health, digital health entrepreneur. So curious about when you look at your radical ideas, those don't seem too radical, right? So why did you choose to call them radical, and then how far are you from looking at those?
Thanks for the question. They're not that radical. It's interesting, sort of I hadn't heard the term the social determinants of health until 2014, and just the idea that people that are stressed out and are dealing with issues, either financial or other things, tend to cost more is not that surprising, actually. But I think probably a third of our LinkedIn feeds, probably there's an article about addressing the social determinants of health. In many ways, it's common sense on that front. I'm optimistic about allowing for reimbursement for non-medical services, just because we're seeing examples, and the private market is already doing it. So I've heard situations like, we don't work with Humana, but I'd heard a story that Humana, in order to help keep people in their home, are actually paying for lawn care services and pest control and house cleaning and things like that, just because it's cheaper to keep them in their home versus putting them in a nursing home. So that's already starting to happen. I know a lot of other plans will build a wheelchair ramp if it's appropriate, where they give the staff a budget of $1,500 to find a vendor to go build a wheelchair ramp. I think I read an article about Anthem, and I'm only mainly seeing it on the payer side, but Anthem paying for home delivery for a small subset of their Medicare Advantage population. So that isn't that radical anymore. I think they probably could do more. Obviously, they can't pay everybody's rent, but in Boston, there's a waiver program, I think an 1113 waiver program, that is allowing more creativity to allow for reimbursement of rent in some situations, and then also for food as well. So there's good movement on that. On the other front, on being able to intervene in real time, it crosses a lot of issues in which I put out there as a more radical issue. One is privacy. It sort of crosses that. So if you're going to do an approach where you find out that somebody's in a crisis, so if, for example, these searches are happening on a hospital system's website, well, you pretty much know they probably were a patient at some point. They probably heard about it. Figuring out whether or not you can help them structurally in that particular moment, that's still to be determined, especially on the provider side. But on the payer side, the incentives are absolutely there because I guess they're at risk. And so depending on that, you can do it in a way that is permission-based by basically asking the anonymous user in this instance, or the anonymous searcher, would you like to talk to somebody? And that could be step one. And by radical, a lot of organizations aren't equipped to have a call center, and to allow for that. But what's interesting is call centers do exist for these very large entities, and they're 24 hours. So do you train a certain team and enact some pilots? I think it's possible. We are seeing, so the question is, are we seeing providers actually navigating for social determinants of health? Yes. And what's driving that is essentially risk sharing agreements that they're getting in place. So what's happening is the C-level suites agreeing to them, and then the care teams are like, we need to do something. They're probably still in the we need to do something phase of things. And part of it might be engaging with a directory like ours, but part of it might be allowing for the building of a new population health team. I know that EMRs are building some really interesting reporting. Epic has something called Healthy Intent. Cerner has something called Healthy something. I forgot the name. Healthy Planet and Healthy Intent. Healthy Intent is with Cerner. Healthy Planet is with Epic. And providers are now starting to run reports to see who is using most of the services. And then what they're doing is standing up population health teams staffed with some social workers and care coordinators who are doing outbound calling or visiting to try to get in front of some of those issues. So that's promising that we see.
Hi, my name is Edna Cadmus, and I serve as the co-lead for the New Jersey Action Coalition. And we move nurses out into the community working on volunteer programs. And I'm just curious in terms of how do you update your website? How do you add resources to your website? And how are we ensured that they actually exist on your website?
Thanks for the question. That's the area where we spend most of our time and energy. We're a service, so although AmpBertha.com is freely available, our customers tend to be those that want the extra features and they level up to a paid service. And so usually our customers are large teams of social workers, but far majority of our users use AmpBertha.com. We're staffed, a little under half of our staff are data quality specialists who are data entering these programs and actually calling and verifying programs. We don't always get it right. So when you're looking at nationwide coverage, things change so rapidly, but we do our best. And so we've been able to build some automation as well. So based on our automation and our staff, about 6,000 programs a night are actually being reviewed. So if, for example, the public policy changes, one of the feeds we subscribe to is something called benefits.gov that tells us about maybe the federal poverty income limit changed on a state-based program. Once we receive that automatically, then it prompts our staff to go and look it up and verify it. One of the things that we realize is that the credibility of the nurses that are out there and the social workers that are out there is on the line. And in some cases, they may be dealing with a skeptical population or somebody who may be intimidated. And so they don't want to spend their last bit of bus money to go to the wrong location. So that's the core of our business is we're the throat to choke to keep the data current so that all the care teams and all the hospitals don't have to at least worry about that part of it. So we're one small cog in the wheel.